So my name is Heather Guidone. I'm the program director of the Center for Endometriosis Care in Atlanta, Georgia. I'm also a board certified health advocate, person with endometriosis for many, many years. And I have worked across the endo space going on almost 3 decades now. And I have really kind of worked really in the trenches, across policy and legislation, research facilitation, support and advocacy, and of course, patient care.
What sorts of patterns and changes have you observed in endometriosis care during the past 30 years?
The most noticeable change, and also one that I applaud the most, is the patient empowerment and education component. Patients advocating for themselves, advocating for each other, people like you who, sort of stand with the advocacy as agency, really trying to make the rising tide lift all the boats. Patients are not sitting idly by being directed how to receive care. They're seeking out care and they're demanding it and they're insisting upon it. And I think that that's fantastic. Although some people still characterize it as a menstrual disease or period disease, unfortunately, more people are pushing back against that narrative. When folks understand the menstrual event, they're able to better respond to it, right? And they're better to self advocate and know when something is wrong, where and when and how to seek help. Endometriosis is absolutely part and parcel of a robust menstrual education program. With that said, we absolutely need to incorporate endometriosis into any kind of health literacy program, be it menstruation or otherwise. Menstrual symptoms are a part of endometriosis for many people. Painful periods, certainly a broad and deep symptom for many folks, but it doesn't end there. That's not the whole story.
Could you tell us a little bit about the approach of the Center for Endometriosis Care when it comes to this disease?
We are all committed personally, individually. We all have a stake in endometriosis, whether it is as a practitioner with our surgeons, people like myself on staff who lived with and struggle with the disease. It's our only focus. We eat, sleep, and breathe endometriosis here. We were founded about 31 years ago as one of the first, really the first centers of expertise in the world that's just focused on endometriosis and pelvic pain gynecopathology. So we're treating things like adenomyosis, we're treating things like fibroids and the other secondary pain generators that often come with endometriosis. But the crux of our approach is surgical excision. That's cutting the disease out. That's not just burning it, leaving it behind to cause pain and symptoms. Also, when you're vaporizing or ablating disease, what's happening is you're leaving it behind and you're burying it under fibrotic scar tissue. You're making it more difficult for the next surgery. So the goal is really to intervene early, intervene properly, knowing when, how, and on which patients to do surgery and when it's right for them, and to limit the number of surgical interventions. What we also do is really serve as an advocacy and resource center, really on a global scale. Our patients come from almost 70 countries. We have many, many patients from Australia, in fact, that come over for care because they're just not able to get it in their own region. So they do make the trips here. And we really owe it to the global endometriosis community to serve as mythbusters, to serve as a barrier against that persistent misinformation, and really serving as a resource center, someplace that folks can go from their corner of the world, learn about the disease, and use it to empower their own choices and their own care seeking.
Most notably, we know about Bindi Irwin, the late Steve Irwin's daughter, flying overseas to the United States for surgery. Why is that happening? And when we're talking about the quality of the surgeries and the type of surgeries, what distinctions are important to be made before seeking care overseas, which we know can be not only financially costly, but if we don't make the right choices, they can be detrimental going forward?
It's an abundance of patients who need care and a lack of true specialty centers. And I can only speak from our personal patient perspective and what's related to us. They're doing that because they're not getting the help locally that they have been seeking. They've been subjected to two, three, four, sometimes more incomplete surgeries, which we talked a little bit about, where, it's actually making the next surgery that much more technically difficult. They're not getting the disease cut out. And I will sort of add a little caveat there and say, Australia is ahead of the game in a lot of ways. They have a really big emphasis on the multidisciplinary aspect, which we also follow. But I'm gathering from our patients that they're missing the surgical component, which is equally as important. You need all of it. You need the entire armamentarium. You need to have diet and nutrition information, pelvic floor therapy. Some folks prefer acupuncture, pain management. They'll be offered, if you have to have surgery, we're just going to vaporize it, and then we're just going to put you on this medication indefinitely. And I think that there's this miscalculation in the community that some of us are anti-imaging, we're anti-medication, we're anti this, we're anti that. We're not. What we are is anti-misinformation and anti-dismissal. I want a patient to have access to all the tools in the box. I want that person to be able to have quality imaging with radiologists who know what they're looking at, who understand the disease, who know that they can't just simply look at the scan and say, we've ruled it out, because you can't. The best radiologists in the world can't rule it out. When we come to things like extrapelvic disease, which we treat such an incredible amount of, you really have to have that interdisciplinary team. If you're not building that surgical OR where you're going to have that cardiothoracic or that colorectal surgeon or that urologist to come in and assist your lead surgeon with their work, as we do, you're leaving disease behind. It really undervalues the role of the surgical approach and how important the right surgical approach is. It's great to focus on all of these other things and all of these multidisciplinary approaches because, yes, of course, it's a systemic disease requiring multidisciplinary and interdisciplinary care. And when you take any one of those components away, you're doing a disservice to the patient. Dr. Sonerbo treats among the highest number of thoracic cases in the world. It's very important, particularly in extrapelvic disease, that can be so very damaging. And it's not just a disease of infertility. When we're focusing our efforts on fertility and the patient's primary outcome goal is to just live their life, that is a disservice to the patient. So what you really need to do is be focusing on your patient, looking at them, asking them, what is important to you? What matters to you? You can't go in to a disease like endometriosis with this little preconceived notion that it fits in this box. This is who gets it. This is how we treat it. And that's the end of it, because it's so different from patient to patient. If you've reached your third medication and you still don't feel better, there's no reason to assume that a fourth or fifth medication is going to help you. So at what point do you stop medicating that patient and say, I think it's time for surgery?
It's interesting to see the same issues and the same stories happening in Australia because endometriosis patients and advocates in Australia have started a petition calling upon RANZCOG, the Royal Australian and New Zealand College of Obstetrician and Gynecologists, to review and revisit their guideline. So we know that $0.49 million was awarded for the clinical practice guideline. What can you tell us about the ACOG guidelines and in terms of what you have heard from advocates in Australia when it comes to what we are seeking, what is missing in the guidelines, and why do you think patients are being so vocal? Why are we
Sure.
all in all these different countries yelling and jumping
The
up and
same
down?
things. At the end of the day, we are really asking for the same things. I have been watching the Australian patient-led campaign, just being totally impressed with the level of knowledge that this patient-led, which you are a part of, campaign has really brought forward. I know that some folks like to call us hysterical Karens. This is not Karen shouting, okay? These are educated, informed, and empowered patients who have so impressively stood on the front lines and said, we are missing money for surgical training to improve access to care. We are missing money towards benefits in the here and now. And that has just been so impressive to watch. And if it is falling on deaf ears, that's very disheartening to me because patients are the ones that drive the change. They're not just objects of change. You can't just administer at them. They are part of the change. In terms of us here in the US, we don't have guidelines per se. What ours is a bulletin. Unfortunately, it is treated like a guideline. It's not that it's useless because it does have some good core components and a good base. It's that it needs to be treated as a priority. This is a public health crisis. ACOG is tasked with recognizing not necessarily the patients because they are a professional institution that represents the doctors, but they're tasked with representing the doctors that represent the patients. We really want to see the disease recognized as that subspecialty because that leads to all other things, including different coding and different strategies and mechanisms being put in place, which will improve and increase access to care. And I think at the end of the day, in all of our respective countries, we're all doing the same things. And what I'm seeing is that we're really having the disease very much pigeonholed. This is a medical therapy disease of periods. Ultimately, if you have fertility issues, that's really what we care about. We really want to see quicker time to diagnoses, and we want to see once they get diagnosed, they're also getting effective care. But again, this is a patient-led movement. This is something that folks like you, EndoWhat, other organizations that are really committed, that are independent and representing the interests of the patients, not the doctors and the donors. And that's really what we need to see.
We know of at least 27 cases in medical literature of this disease actually occurring in biological men, cis
Yes,
men. And
yes,
we found it in fetuses, stillborns,
yes,
postmenopause, post-hysterectomy, hamsters,
correct.
guinea pigs, macaque monkeys.
We still don't know what absolutely causes it. We have no prevention. We have no definitive cure. Although excision combined with multidisciplinary care can offer you the best outcome, it's still not a cure in and of itself. So there's all of this mystery that still continues to enshroud the disease when people are so definitively writing guidelines as though we have answers. We don't. So there needs to be room to evolve and grow instead of putting the disease in a little box and making it fit our hypotheses. We really need to be so much more open minded and really much more patient centric and ensure that we're treating each patient on their own merits.
Even within the foundational document that the Australian guideline is based on, which is the NICE guideline,
Yeah,
it specifies how things like Chinese medicine are not necessarily helpful and can actually be detrimental for some patients. It might help for some people with symptom management, but it's not really going to do that much for your lung collapses or your silent kidney death. So I think it's
right.
important to put that as a little caveat that even though in Australia they do outline that we just don't know enough, what do we know? Because we know that even the person who invented the theory of retrograde menstruation, that specifically first and second line tier treatments are based on, what did John Sampson have to say when it comes to endometriosis, specifically to that theory of retrograde menstruation? What does it cover and what doesn't it cover?
He being the founding father of the retrograde theory, even he recognized that it's not as simple a case as native endometrium being flummoxed throughout the body. So he called it endometrial-like, but he also said, I recognize that it can't just be retrograde menstruation. Those of us that really sort of follow and have delved into what he actually really said, we're called flat earthers and things like that. Fact of the matter is, about 90% of people with periods experience retrograde menstruation. 10% will develop endometriosis. Okay. He acknowledged that it's not just simply aberrant native endometrium and that it can't all be caused by retrograde menstruation. There's this real lazy science. Again, we've put it in a box, right? We've put it into this box that it's definitely caused by backwards periods, and we've got to rip the uterus out and we've got to treat it as a menstrual disease. But that's not really what he said. And if he had the context of today's technology and today's research and understanding, I'm quite certain that his own words would have evolved even further.
Not to mention that there are patients out there who are having lung collapses in the absence of any pelvic pathology at all.
And men, cis
And
men.
then, have you had any cases at the CEC of patients who no longer have uteruses, who have had hysterectomy, but have quite complex extrapelvic disease?
Absolutely. Sciatic, post-hysterectomy, cardiothoracic, thoracic diaphragmatic, of course, abdominopelvic. We see a lot of patients post-hysterectomy who have persistent disease, or sometimes they call it recurrence. I like to think of it as persistence because it wasn't removed in the first place. So it's not really a recurrence. It's disease that's just still there. Medical therapy can play a role, even post-hysterectomy, but you're only treating the pain and the symptoms. You're not treating the lesion. And that's where the disconnect is, I think, in a lot of these guidelines or There's this huge emphasis on medical therapy, non-surgery, non-surgery, don't do surgery, surgery is harmful. Well, yeah, anything is harmful in the hands of someone who's not capable of doing it. Not all pelvic pain is endometriosis. We know that. And not all endometriosis causes pelvic pain. It's great to have these clinics, but what do I do when I get to the clinic and I need surgery? Now what? Where's the surgical training component? That's my question. Dr. Sonervo in particular has always run a surgical fellowship. And when I say surgical fellowship, I'm not simply talking about minimally invasive gynecologic surgery or what we call MIGS, right? This is an actual excision fellowship. We've trained, or he's trained many, many surgeons who have gone on to open their own centers or work at other centers. Definitely have, a very robust surgical training program specifically for excision.
What advice do you have for Australian endometriosis patients or those who suspect that they have endometriosis and they're just starting the diagnosis journey?
Well, first of all, you want to find like-minded others. I tell folks all the time, there's a lot of associations and organizations and folks out there. Find the ones that align with your beliefs and values, that you feel supported by, that you feel educated by, that are putting out authoritative education information, resources like yours, resources like Diane's, some of the other really powerful advocates that are over there. You're doing incredible work. It gives me, it warms my heart. It really does, because we didn't always have such a robust global community in years past. So seeing now the work that you are all doing is just so wonderful. And I would say, you are your own best advocate. Nobody's going to advocate for you the way you will. And I tell people, step outside of yourself for a moment. We often tend to put ourselves last on the list. Step outside of yourself. Pretend this is your mother or a family member or your partner or someone that you love and care for. Advocate for yourself the way you would for somebody else. Fight as hard for you, if not harder, as you would for someone else. You have a divine right to be treated with respect and integrity at every step of your medical care. If you feel you're not being heard, if you feel you're screaming in silence, you're screaming to be heard, find someone else who will help. And I fully recognize and understand the privilege that is associated with care for this disease. I know that not all of us can access it. That is another component that we have been working on for a very long time to try to improve access, particularly for under-resourced communities. We are working on it. We are trying. We are doing the work. We're putting in the work. We're trying to do it. I recognize that not all of us can access it right now. Find the best help you can where you are. That's really the best thing that you can do, but advocate for yourself. That's the key. We spend 15 minutes in a doctor's office. We spend our lifetime in our body. The impact of a lesion on a body is seismic, and we're not just treating a lesion, we're treating human beings. We're treating people, humans. So look for someone that is going to believe you, someone that helps you. You do not have to be gaslit. There is another doctor out there who will listen to you. But surround yourself, find your allies, find your advocates, find your squad. Those are the people that are going to help uplift you. They're going to educate you. They're going to empower you. They're going to help you. Because really it does take a village. I know that's such, trite. But it does. It takes a village. I mean, there were people that helped me along my journey, as pen pals back in the day in the late 80s. We wrote letters to each other. Now it's just a click of a mobile phone. But, find others like you that sort of align with your beliefs and your value and your goals, because you're not alone. I know it feels isolating and I know you feel alone, but you're not. There's a lot of us out here.
Well, Heather Guidone, I am absolutely, absolutely so grateful that you've joined us. On behalf of the Australian community, from the bottom of my heart, thank you so much for sharing your wisdom with us. 30 years of experience in this space is nothing to be laughed at, and we absolutely stand on the shoulders of giants like yourself, and we're absolutely grateful that you've joined us.
As do I. As do I. It's a Sisyphean effort. A lot of times we feel like we're pushing that boulder uphill over and over and over. And, I myself experience, feeling jaded, feeling disheartened, feeling like we're 2 steps ahead, five back. But then I talk to folks like you, and I'm reinvigorated and I'm re-inspired. So thank you for the work that you are doing, because really you are carrying the torch.
Thank you so much.